David Clark is professor of anesthesiology at Stanford University and the director of the Palo Alto VA Pain Service. He is also a handling editor of anesthesiology. He has been for many years co-supervising a laboratory focused on the study of pain occurring after trauma and surgery, including complex regional pain syndrome, using animal models and, more recently, human subjects. His laboratory studies have helped us to understand the role of peripheral pain mediators in supporting not only acute pain, but also in fostering the transition of acute pain to a more chronic, disabling form. Dave received his bachelor's degree in chemistry from Carleton College and an MD and PhD from Vanderbilt. He has a long track record of NIH funding and is the author of nearly 150 peer-reviewed papers. We've asked David to speak as a follow-up to his fine recent editorial in anesthesiology entitled Preclinical Pain Research, Can We Do Better? The title of his talk today, again, is Animal Models and Translational Pain Research. David?
All right. Well, thank you very much. Please. I appreciate very much you taking your afternoon, and I appreciate being invited, Mike, to present to the group. This is a little unusual for me, talking about something for which I didn't actually have to collect any data for. I just had to, in my own frustration, sort of put together some slides which really reflect honestly the efforts of many others in trying to unravel some of the difficulties we've had. So I don't have any particular disclosures to tell you about. I don't think I'm unduly influenced here in anything that I'll say. So, you know, if you'll open the cover of a pain journal, of an anesthesia journal, or flip through the covers even of lay press things you'd think would have no trouble in controlling pain. We have all kinds of treatments around, right? We have complementary and alternative medicine stuff like acupuncture and herbal therapy. We have medications, and we can inject the medications, and psychology and physical therapy, and on and on. But the truth is, and as was mentioned this morning, when we have many medicines, we have few cures. As January Mao pointed out, most of this stuff doesn't work very well. And in fact, our list of possible treatments hasn't changed very much in the last 20 years. So in 1997, when I was a junior attending, I would have hopped on up to the bedside or the exam room and said, well, let's talk about possible treatments, and maybe gone down a list of things like nonsteroidals and opioids and anticonvulsants, turn pain relievers, medicines like that. And you know, the problem is today, some 20 years later, the list of things that I would talk about, or you would talk about, it's essentially the same. There have been some changes in formulations for sure, and a few new medicines, but few new chemical entities. We have things like Botox and botulinum and omega conotoxin, but the number of patients that those are useful for is really pretty narrow. So what is the problem here? Well, one problem is that if we look at how many drugs entering phase 1 trials actually make it through phase 3 to receive a license from the FDA, we're talking for pain relievers of only about 10%. And I've got to tell you, even that number struck me as a little optimistic. So if you dig into it, you'll find that lots of those aren't truly new drug classes, but you know, maybe different opioids that have come along in the last 10 years or so. We knew that they were pain relievers. Somebody had to take the time to show that they were safe, perhaps, or work out their properties. But it's a minority in any case. And the failures that we're having are tremendously expensive. So if you look across the screen here for the costs during different phases of clinical testing for a number of different types of medications, you'll see they're similar for phase 1 and phase 2, but then you have this big purple thumb sticking up here in phase 3, and for overall costs. Those are pain-related drugs. Those are analgesics. The reasons for that might not be entirely clear, but it has to do with the number of patients you need to put in the trials, the difficulty in keeping people enrolled in the trial, and the outcome measures that need to be used. So it's tremendously expensive, and again, not many of these are working out. So the idea that we've had is that if you optimize preclinical testing, you might be able to reduce some of the wasted money that you have here. So that sounds like a straightforward enough idea. Here's a big problem, though, that's come up in the last few years, and that is that major parts of the preclinical reports we use, this is not specific to pain in any way, but just preclinical data, seems not to be very reproducible when another laboratory tries to do similar experiments, or a pharmaceutical company attempts to use the data on which to build a platform for development of a new drug. And so there have been a number of studies now trying to quantify how many studies are largely reproducible versus not reproducible in critical ways. And the number of studies that are reproducible is less than 50% in all cases. This is actually an irreproducibility index here. So irreproducible from 51 to 89%. It's a huge number. You can look a little more closely at why that might be. And of course, that's less than clear as well. But amongst the reasons are problems in the assumptions of the specificity and qualities of the biological agents or materials that are used in the studies, problems in the intrinsic problems in the study design itself, and as Tim is going to talk to us about in some detail, problems with data analysis. And again, this isn't an inexpensive problem. So we spend more than $50 billion a year in so-called preclinical testing, probably half of it not being terribly reproducible. That's, you know, $1 billion here, $1 billion there. Pretty soon you're talking about a lot of money. So what can we do then to make preclinical testing more reliable, more reproducible? Well, in an odd sort of reverse translational sense, we could look to what's been going on in the human clinical world, and we can look at consort guidelines. I imagine everyone in the room is familiar with what consort guidelines are. They were designed to enhance the reproducibility and transparency of how clinical trials are conducted, and that's fantastic. It's only after that that we developed the ARRIVE guidelines that I'll present to you in just a moment, and they are very similar in the sense that they attempt to provide some transparency in the design and conduct of these preclinical trials. And you should be aware there are some other efforts that have been made over the years as well. You might have read the P-Precise effort, which is really very similar to ARRIVE, and some of you working, for example, in the field of neuroscience might be aware that the NIH has had very focused efforts on trying to improve the outcomes, for example, in stroke trials that follow this same sort of pattern. So what the ARRIVE guidelines are is it amounts to a checklist. One of the last things I did before getting on the plane yesterday was to help a lab member fill out the ARRIVE checklist for the submission of a publication. And some of these things are kind of things you'd think you'd really already be doing. I hope you would already be doing many of the things that are on here, like writing having an accurate title. I think we can handle that one. But in the discussion, talking about generalization and interpretation, revealing funding sources, but there are a few key elements here that probably do require some changes in how many of us conduct our studies, and that has to do with talking about blinding and randomization when we allocate animals to treatment groups and when we test the animals. Very important. I'll tell you, up until several years ago, we didn't blind our observers, and that turned out to be a problem. We caught ourselves in some observations thing. One person sees one thing, one sees another. What's going on here? Statistical methods. Again, Tim is going to talk to us about the importance in some of those things. The ARRIVE guidelines have caught on as far as in their checklist form. Many journals now require these things. We do not know, I would have to point out, on this date whether following ARRIVE guidelines will really lead to more reproducible data or not. Nevertheless, we've staked some of our future in that area. In my mind, more serious are the hard questions we have to ask about the animal models that we're using. That is, are they valid and reliable? Is the physiology that we're studying in the animal probably similar to what we see in the humans? And the measures that we're making. So we have a pain model in this case. How are we measuring pain? Is it a valid reflection of what we observe in a human or what a human complains about? What is the dimension of pain that this thing the animal is doing might in fact inform us about? So to start with the models, let's just take a look at the face validity of some of the models. Some of the most common forms of neuropathic pain that our drugs are developed ostensibly to treat are things like post-herpetic neuralgia or diabetic neuropathy, other forms of peripheral neuropathy. You might hear this is a case of shingles. You have infection and inflammation of primary nerves in that case. Is it well modeled by making a nerve injury, as frankly we do in the laboratory? Do you expect a nerve injury model made with suture to be something like what this pain experiences? Or if what you want to do is study arthritis, arguably our most common cause of chronic pain in the country, if not one of them, can you get a handle on that by injecting Freund's adjuvant under the skin of the hind paw? We call them both inflammatory, but is that a valid thing to do? Now, on the other hand, and to credit our own field, we have some efforts at making better models. Dr. Brennan, a number of years ago, developed the incisional pain model, which looks pretty close to what you see in surgery sometimes and does involve the same tissues and hopefully some of the same mechanisms. In our own laboratory, we've developed a fracture cast model of complex regional pain syndrome and persistent postoperative pain, and in fact it involves the maneuvers which most commonly lead to CRPS, which is limb fracture followed by immobilization. That does not guarantee translatable outcome, but perhaps is a step towards it. So I'll just explain the sorts of considerations then we had when we developed the fracture cast model. Was we did try to mimic the etiologies of the disease. We fractured tibias and put the animals in casts until we had a relatively mature bone callus, which is similar to what happens in humans. It's several weeks in the mice and rats. Yes, it looks ridiculous. Our vets hate it, but that's what we do. And when we look at the non-pain outcomes in the animal, they match what we see in the humans with acute forms of CRPS, like extravasation of protein from the vasculature, warmth, which reflects an increased blood flow, trophic changes, osteopenia, and finally multiple dimensions of pain as we measure them. We'll get to that in the laboratory, like functional changes as well as allodynia. And so on. So we've made some progress there. But what about other factors that we know impact pain that we don't always model in the laboratory, like the impact of sex on what we see in the laboratory with our models and how it impacts pain in the general community? In humans, we know that an individual's sex can affect the likelihood of developing a painful disease, comorbidities that might be experienced, and responses to analgesics, including side effects to those analgesics. We know in animals for a fact now that many of the same things exist. Different animals of different sexes will have different degrees of allodynia or other pain-related changes. When they are injured, they will respond differently to analgesics, and the actual mechanisms can be different in male and female animals. In fact, now the NIH, if you've filled out an application recently, will ask that you specifically address things like how you are looking at possible sex differences in your animal cohorts. And you can say you're going to do it or you're not going to do it for the following reasons, but it needs to be addressed these days. So these are some data that underscore why it is you'd want to use animals of different sexes. These are from the Mogul group who's had a series of reports on the sex differences between animals. They took up the question of why they're interested in why so many glial modulating drugs have not really translated very well in clinic, and took male animals, did a simple nerve ligation model, very robust and common, and injected intrathecally minocycline. Minocycline is a so-called glial modulating drug. Yes, it's an antibiotic too, but what it did in their hands is what it does in everyone's hands in this model, which is to reverse allodynia time course, and that's just beautiful. And it doesn't matter which pain model you use or whether it's acute or chronic. It just works very well in the male animals. Then they took female animals, made the same nerve ligation. Sure enough, they became sensitive to the poking at their paws. Only when they had the minocycline injected, what happened to their pain thresholds was absolutely nothing. There was no response at all. We've been studying glia for decades, literally decades, with a lot of enthusiasm behind translating these things. And here we are just realizing very recently that those test drugs, many of them, have no effect in female animals. Would we have had the same enthusiasm to try to translate the results, having these results in hand earlier on in considerations. What about genetics more generally? So we know that genetics also play an important role in pain. For example, we can do twin studies. This is where you compare monozygotic and dizygotic twins. Those are identicals and fraternals. And you say, well, what about pain thresholds between these individuals? And what about the development of disease states? And in fact, whether it's pain sensitivity, developing pain-related diseases, responding to analgesic side effects from analgesics, all of them have genetic components between maybe 15 and 50% if you need to put some numbers on there. We have a few examples of where genetic lesions lead to very profound changes in pain sensitivity. You may be familiar with what happens if you don't have NAV 1.7 ion channels. This one actually made Time magazine. What happens is you have congenital insensitivity to pain. It is a very bad thing. You don't want that. These people self-mutilate and die, but it's a dramatic example of what a single genetic lesion can do. More probably affecting our day-to-day pain experiences and differences between individuals are complex differences which have to do with polymorphisms in many genes. This is very difficult to sort out. It turns out there are probably hundreds and hundreds of genes involved in this kind of problem. But typically in pain studies, we don't take into account the possibility of genetic differences when we look at robustness of effects much at all. So this is what it looks like in a laboratory. These are some data from our own laboratory looking at so-called phase 2 formalin effects. You inject formalin in the hind paw of an animal, it'll lick its paw for a while and then seem to get better, and then there's this phase 2 effect. Most of the people are interested in phase 2. It seems to reflect sensitization in the spinal cord, and this is a mechanism that supports chronic pain, so there's a lot of enthusiasm around it, but how much of that behavior you measure depends entirely on the strain of animal that you take. So here are a lot of different strains of mice that we tested. Some animals, a whole lot of phase 2 licking, some hardly any at all. These are the Z-scores that show you the diversity here. So whether or not you believe that that phase 2 exists or is important and how much you measure will depend very profoundly on the genetics of the animal. Of course, the silver lining in all of this is if you are a person who does genetic mapping, you can exploit those differences between the strains to let you know genetically what's going on. But the bigger point is that what you see in the animal model depends on what animal you order from Jackson Labs. And we are very stuck, by the way, on looking at rodents. Why do we look at rodents? Well, they cost less. That is not to say they're inexpensive. Many of you do laboratory work. You probably, unless you get better deals than I do, you might spend $30 a piece on your mice unless you breed them yourself. So they're not cheap, but they are less expensive than using horses, for example. They're socially acceptable. We don't seem to mind bumping off a few rats, but don't go messing with our companion dogs and so on. That sort of raises a different level of concern. On the other hand, there are big advantages to using large animals, and there is a push to use more of these at some point in preclinical trials. For example, their physiology and PK/PD is often more similar to humans than is the functioning of a mouse. There is the natural occurrence of diseases we're interested in studying, especially osteoarthritis, but cancer, neuropathy, other injury-related pains all happen to animals and offer us the opportunity to study them. There are some things that are actually easier to measure in a large animal. You can image a larger brain easier, for example. If you want to measure gait parameters, you can do that in a more straightforward way in some larger species than in small ones. And in fact, for many species, they're well worked out pain assays, even if you want to inject an algogen or ligate a nerve or do something like that. Now, this is an example from Mike Iadarola, who he's interested in this compound resiniferatoxin, okay? And I'm going to abbreviate that RTX, resiniferatoxin. If you don't know what it is a TRPV1 channel agonist. So it opens up the TRPV1 channel. If you do that, if you inject it intrathecally, what it does is it kills nociceptive neurons that express these TRPV1 channels. You'd expect it to reduce pain. So what he did in an effort to translate this towards palliative use in humans was to use companion dogs that happened to have cancers. They were anesthetized. He intrathecally injected, looks like 1.2 mics per kilo, resiniferatoxin, woke them up and sent the dogs home with breakthrough analgesics. And the outcome then they used in this cancer pain reduction trial was how long would that dog do well with just the breakthrough analgesic before the owner came back, having used a dog version of the brief pain inventory, saying that this animal isn't doing so well anymore. And what you see here is a separation between groups that got active drug versus placebo. And what happened was the dogs with active drug lived longer with a lower degree of this owner-applied pain scale than did the placebo-treated dogs. And this at 6 weeks, this just shows you about half the animals with RTX still were doing pretty well, whereas less than a quarter of them were doing well after the placebo injection. So it's just one example of how you can use a larger animal model to study a very relevant pain in an effort to get that drug closer to testing in humans, which I think is where that drug stands at this point. On to the measures we use. You probably, you might have perked up there a little bit when I told you about the dog version of the brief pain inventory. I mean, some of this, we have to think about how we are actually trying to get at pain when we talk about an animal and its behaviors and trying to compare that to what a human might actually be experiencing. Most commonly, what we do is we use so-called reflexive or evoked testing. This usually involves a thermal or mechanical stimulus. Often you put an animal on a wire screen so you can get at its paws, which is usually where you've caused a sensitization. And here is one of our lab members poking at the paw of the rat. And sooner or later it's going to withdraw its paw, and we call that a withdraw threshold. And if you don't need as stiff a von Frey fiber, well, it must be sensitive and experience more pain, right? Well, that is all quick and easy and straightforward and inexpensive and easy to treat people to do, and it might even reflect something like what you experience when you step on a tack, I suppose. But here's this is the patient I see in clinic, right? That patient comes in saying something like, hey, my pain is almost always there. It keeps me awake. It doesn't allow me to think. I'm not interacting with my family. I'm not going to work, and I feel depressed. It is hard to get at those problems looking at paw moving away from von Frey filament, right? So clearly we have a bit of a challenge here, and we have to think about how we might move from reflexive testing to measuring something which, at least on its face, would seem to understand what's going on with this young woman in the picture. By the way, we can ask the direct question, if you reduce something like hyperalgesia or allodynia in humans, does that lead to lower pain scores? Because that is what we're trying to measure in the animals, right, is allodynia and hyperalgesia. I think Evan still allows us to use those words in anesthesiology. If you do that, it turns out you're still probably not measuring parameters which in many people reflect the underlying pain. So Jim Eisenach and Rick Rout did a study that was published just a couple years ago where they took patients with complex regional pain syndrome. Again, this is a pain syndrome that's characterized by hyperalgesia and allodynia. Okay, so those are real live clinical features of that particular pain syndrome. They injected them intrathecally with clonidine and adenosine. They followed hyperalgesia and allodynia and asked them, how much overall pain are you having? Okay, so that was great. It's a nice, simple study, and this is what happens when they plot hyperalgesia versus pain or allodynia versus pain for adenosine and clonidine. What you see is essentially a shotgun, right? So there was no statistical relationship between hyperalgesia or allodynia and the amount of pain overall the patient was reporting. So how can you use allodynia as your index of pain? The study really begs that question, and I'm afraid it's pretty discouraging. So what are we doing? What are we doing nowadays? Well, you will find journals raising their bars, I think, not just anesthesiology, but many, to where reflexive testing may be incorporated in the studies, but there might be an insistence or a strong encouragement to use other assays which could be a little more informative. Many of them have to do with what I would term a sort of body language of the animal. For example, instead of withdrawal, you might look at flinching and guarding after something is injected that's noxious or after an incision is made. There can be postural or weight-bearing changes. We like that one when we use limb injury. In fact, it looks at an animal's volitional unweighting of a limb that has been injured and it's responsive to analgesics. Some much more sophisticated stuff has been done, like doing video-assisted facial analysis. They look specifically at positions of ears, eyes, mouth, and whiskers, as well as the overall head, and relate it to analgesic-sensitive changes in the animals and various pain models. ultrasonic vocalizations, you know, animals screaming that we really can't hear can be incorporated. And finally, there are some even more sophisticated things that use operant testing, or a simpler version using simple conditioned place preference, which you might recognize from addiction-related studies where an animal is exposed to a drug in one room and a placebo in another, and then you eventually put the animal in the middle and ask, do you want to go that way or that way? And presumably it would go to the room where it experienced the pain relief if in fact the drug was a pain-relieving drug. Using studies like this, Drs. Pareca and now many laboratories have shown, and this is an incisional pain model, I thought I'd show this particular audience, but many others, that in fact if you do something like a nerve block, which should reduce nociceptive information, the animal will go to the room where it experienced, where it was placed after receiving a nerve block, at least for a day or so after surgery, but that sort of response has gone after 4, suggesting that the spontaneous pain-like or aversive state that the animal was in had disappeared by that point. Gait analysis I'm going to mention as a functional outcome. We're all about functional outcomes, and you know, if you write a clinical trial to do pain, you're probably going to talk about the functional measures we would use. Well, you can do them using animals as well. Again, for limb injury, gait is one that people often turn to. It's been used in osteoarthritis and in CRPS, chemotherapy-induced pain, and so on. And there are various versions of how you do this. This is a very fancy video-assisted technique that we spend a lot of time with. Turns out it probably isn't any more sensitive than a blinded observer looking at gait. In any case, you can look at gait as one sort of functional outcome. So I'm going to leave you with maybe not a completely justified, but an opinion anyways, how we might look at preclinical models and what some of the considerations we might use. And here I would just end by saying, for studies where you're really trying to discover something, you think you have a new enzyme identified, or a neural circuit, or a cell, or something that's really novel, hasn't been described before, you need to very clearly demonstrate under rigorously controlled circumstances that it might be a player in a nociceptive signaling system. There, it makes sense to use a fairly narrow, reproducible outcome and spend the time in the study on things like how you are manipulating the system to demonstrate that it can impact that one well-defined endpoint. That would be a sort of pathway analysis, or something that required this sort of longitudinal look where you want to keep as much extraneous variance out of the situation as possible. But when we are in the commonly encountered situation where we're preparing a drug or a technique of some kind for translation potential, that's when we have to insist on latitude. We need to look at things like sex impact, genetics, maybe using different species, and incorporating some of the other variables that impact pain and variables that we know impact responses to analgesics. Other ones would be age, comorbid conditions, which we can induce the animals and make sure things like PK and PD match in our animal species what we think we'll encounter in the humans. With that, I want to thank again the group for staying awake after lunch, and Mike for inviting me, and I'll step down.
So I want to thank David for that very thoughtful and thought-provoking presentation. Let's take the time for 2 to 3 comments or questions, if you have any, please, before we move on. Any questions, comments? Mohammed.
Thanks so much. I cannot agree more with you. The problem actually with drug development, especially when you look at the right model, which can reflect the human, is really very difficult. And I think the primates is the closest model. But primates needs a lot of money, and there's so many issues with that as well. So in reality, we don't really have a good model which can reflect exactly the safety, I'm talking at least the safety of the drugs. Because the dogs, for example, enzymes are different, they vomit for anything, and they are not the ideal model which is currently used by FDA. So this is an issue which really need to be addressed, and I don't know how. Should we have a humanized animal model to be used? Some people are doing that, but I don't know how it's the validity of this. Thank you.
So this, I'm afraid I don't have an easy way to get around all of those problems. I think we have to be thoughtful in using other models, because a problem you can run into, I believe, is just doing a lot more testing in other species and using other tests which are no more informative than what you started with. So there should be a definite advantage in moving up the phylogenetic tree there in using other models. I am a proponent of dogs and perhaps horses for some of the arthritic conditions, because it is a naturally occurring disease, and the tools that we use there can be relatively robust. They are not a panacea, and I agree that I think we are not in position as a society perhaps to start using primates for all of our pain testing research.
Thank you again, David. It was very nice.